Thank you all for joining the MOOC webinar on trauma-informed care and working with survivors of torture with Sue Pichet and Eric Wirtz. The Physiopedia Plus MOOC on displaced persons is supported by the USAID-funded project Learning, Acting, Building for Rehabilitation and Health Systems, better known as RELAB-HS. So today we are here to listen to Sue Pichet and Eric Wirtz speak about a topic that is close to their professional hearts. So Sue is a Canadian registered nurse and a certified nurse in psychiatric and mental health. She brings over 25 years of experience as a military nurse with the Canadian Armed Forces and has worked in war-torn locations such as Sarajevo, Kosovo, Afghanistan, operations in Europe, and acute care settings in Canada. So Sue, we definitely appreciate your willingness to be here today and to provide us with your invaluable point of view on a topic that is of growing concern around the world. So Sue, I invite you to start the conversation on trauma-informed care.
Thank you, Amanda. I was privileged to be part of the production of PhysioPlus's program, Understanding Rehabilitation Needs of Displaced Persons. And I don't want to repeat anything that I've already put forward in the third session of the program, but I'm going to just go over a few basics of what trauma-informed care is and expand on why and how of trauma-informed care. And then I'll pass it over to Eric, who definitely has the more specific point of view than I do. Trauma-informed care encompasses a healthy, informed attitude maintained by all staff towards every client served and with the whole client in mind at all times. That's a bit of a mouthful of words, but basically it's if your facility or organization is trauma informed, then everyone, including you, will see the individual that's sitting in front of you as more than just the injury or the demographic or a set of vital signs. And why should we follow this approach? Well, you can safely assume that every client, person that you speak to has underlying issues that you can't see. And one of the more statistically prevalent issues are ACEs, adverse childhood experiences. And they're far more common than we previously thought. And yet research in this area is still lacking in unstable or lower and middle income countries. So these are countries that are actually more susceptible for the risks. Those are ethnic and racial minorities, people with less than a high school education, poverty, lower income, unemployed or unable to work, or people who are identified as gay, lesbian, or bisexual, the LGBTQ population. But it's significant to point out that even with the research that we have at this point in time, globally, 33 to 88% of people, depending on the country, have experienced ACEs. So because of this, as I said in the start of it, that you can safely say that person sitting in front of you, statistically speaking, probably has some sort of adverse reaction, adverse experience in their past. The number only increases when we start thinking about adult traumatic experiences. And there's a demonstrated dose-response relationship between the ACE score. So the more adverse childhood experiences you have, then the more negative adult health issue outcomes you have as well. Non-communicable diseases, NCDs, such as somatic complaints, sleep disturbances, gastrointestinal, obesity, cardiovascular, neurological, musculoskeletal, respiratory, dermatological disorders, urological problems, and substance use disorders. That's broad categories of negative adult health outcomes that are affected by trauma. And ACEs are what we've looked at specifically with regard to childhood. And then on top of that, you add trauma from adulthood, whether you're dealing with someone in these cases with displaced persons, it may be due to climate or war or whatever the reason, it's trauma on top of trauma on top of trauma. And so it's peeling back the layers of that. And And now how do we go about doing that? So when I did the MOOC, we talked about 6 principles and discussed the 4 R's, the assumptions. And that's your background information that you need in order to build your trauma-informed care. So the 6 principles are just guiding foundations, and your 4 R's, the assumptions, should be the things that your team will try to seek to obtain. So what you're really trying to do is take the adverse childhood experiences, all the negative stuff. You're trying to take the negative stuff and you're trying to offset that with positive things. If you're dealing with children, then you're going to want to try to give them more positive childhood experiences to offset those adverse childhood experiences. With adults, they may already have unhealthy coping mechanisms, so you want to bring to the table more healthy coping mechanisms. So introducing them to better tools that they can use. You want to take them out of or help them within any difficult situation, and you want to prevent re-traumatizations by way of providing supportive communities and better healthcare services. Altogether, by doing that, improving the positive, and you're offsetting the negative that's already happened and they've already built on, you're building their resilience. You're giving the client more tools that they can work with so that they can better help themselves and heal through this whole process. So now, how do we do this? By taking those foundations and using the principles and assumptions, we look at trauma-informed care. Trauma-informed care is the processes. So what I've often tried to make clear is that as a particular clinician, if you are specific care focused, perhaps you're focusing on treating PTSD clients and you're dealing with a certain kind of therapy. That's specific care. That's the content of the services that are going to be provided. However, informed care is a whole facility, and I don't have to have a clinician there who's working with somebody with PTSD. That facility, I might be providing intake for displaced persons who are coming from say a transport from a boat or from a plane, and they're deplaning, and I'm the one who's registering everybody who comes off. So that I can do still with being trauma informed. So it's a process, and everyone in the process is trauma informed, meaning that they realize that everyone has had trauma. They recognize signs and symptoms. So there's been some training beforehand in the organization, or even with yourself if your organization is not as focused on trauma-informed care. Because you also need to look at not just your clients, but your colleagues. And trauma-informed means realizing that it happens to everyone, recognizing it in others and in yourself and your colleagues. And then you're responding with knowledge and things that you do. For example, if you're sitting someone down and you're going to be asking questions, then you're going to be maybe thinking, oh, okay, well, if this person's gone through trauma, they might be distrustful. So maybe they want their back towards the wall and they want to be able to see the door. So think about those kind of things when you set up rooms for clients, and think about how you deliver questions. So they're not delivered in an interrogation sort of manner. It's more of a conversational manner. I know it becomes a lot more difficult when you have to use an interpreter, but I'm just giving you the basics here, sort of thing. So just keep in mind, trauma-informed care is a whole process anywhere, whether we're doing healthcare or whether we're just doing anything with any of those clients. It's informing all of our staff and having everybody from the person who cleans the floor to the person who's giving out the blankets. Everyone needs to be aware of this. Trauma triggers coping strategies. So whatever the event is, whatever has happened to that person, whenever it's happened, it triggers the coping mechanisms within that individual. And that triggers the effects and behaviors and the health that you're seeing now in front of you. So when you see someone who perhaps is irritable or not happy, pushing back with any of the questions that you're asking them, we can get very defensive ourselves as healthcare personnel, or anyone who's being instructed that you need to do this for the people coming through, and you're trying to do your job, but then you get some individuals that are giving you some difficulty. And you need to remember, this is part of that whole realization process, is that they've been through something, and it's that something that's causing them to do what they're doing now. So just keep this in mind as you're talking to these people, these clients who come through to you. If the traumatic event happened, for example, as a child, so they've been through an ACE, for example, and as a child, they're not able to process that, but they were able to try a beer from the fridge, and they found that, oh, that makes me feel better. So they're on the road to substance abuse. So this child then may grow up to be an adult who becomes an alcoholic. And that child who becomes an alcoholic then in turn gives their own child an ACE that they have to deal with. So this is the means by which we cause an intergenerational ACE transmission. So the point of trauma-informed care is to try to mitigate or decrease or stop the whole process that keeps these unhealthy lifestyles and coping strategies to be perpetuated from generation to generation. And if we can keep that in mind when we're dealing with everything, we help the client in front of us immediately, but we also help everybody else around them and intergenerationally. Every time a client accesses a social service, and by social service, I mean, it could be where they have to register for housing when they get somewhere, or maybe they have to register their profession, or maybe it's passports or it's driver's license. Any social service or healthcare facility that they're at risk for re-traumatization, because all of these associations tend to, in the past, tend to be, this is the organization and this is the client. So we've had a separation. Trauma-informed care attempts to take the playing field and level it out so that we are together working on something. So the concept within the principles that we talked about earlier, the concept is to make the client feel safe, that they're part of the process, to teach them why the trauma that they've been through before is causing some of the issues that they're going through now, and give them the tools that they need in order to resolve those things. I'm making it sound a wee bit easier than it is in reality, but those are the basic concepts that we need to be following with trauma-informed care. So what I'd like you to think about going forward with something like this is not to look at that client in front of you as the injured leg, the fracture, the set of vital signs that has a temperature that's too high, or the demographics, where they've come from, and what kind of profession they have. I want you to look at that and go, what's happened? Because it's not what's wrong, it's what's happened. Tell me about it. Let's work through it. Let me help you out. That's what I'd like you to think about. I know there's lots more to that, and I'm open for questions later, but right now I'm going to turn it over to Eric, and he's going to talk to you more about a specific topic with regards to torture victims. Thank you very much.
Thank you, Sue, for your invaluable insight and thoughtful presentation. Eric, this is your opportunity to tell us more about your experiences working with survivors of torture in a rehabilitation setting. Welcome, Eric. Eric is a physiotherapist and the rehabilitation specialist for emergency and preparedness response at Humanity and Inclusion. Eric has extensive experience working with displaced persons through all stages of the migration process and in a wide range of settings, including the Middle East, Southeast Asia, and Africa. Thank you for being here today, Eric, and for sharing your experiences.
Thank you, Amanda. Thank you, Suzanne and Naomi. Well, I will be the last one that will present you in a few slides my more clinical lived experience and mainly humanitarian settings on the perspective of functional rehabilitation for a displaced person, and then more particularly for survivors of torture. The issues I will try to explain come more from a clinical practice setting, which means it's a more a reality where survivors of torture have been are seeking services and then not necessarily being detected as being a person as a survivor of torture. On the other hand, I will also explain a bit the challenges of managing the organizational aspects of the care, on how the pathway of care of a person that is in need will reach the right service, or the service that he thinks makes sense for him. Of course, there is a perspective of the issues of dedicated care for survivors of torture, with specific techniques and specific approaches that are known to be helping. And of course, my other entry point is also the numerous areas in the worldwide where survivors of torture are living, but they are not being detected as such, and they're only seeking services that are available, but then these services probably will not answer to their needs. And it is up to a humanitarian setting maybe that should look into how to make that environment much more accessible for them, for their specific needs. So this is a bit the challenges that I want to put forward in these humanitarian in the humanitarian sector on the approach towards survivors of torture. So this will be a bit my overview on of course the value added practice and the considerations for the enhancement in migrant care. We know that worldwide now, and I think the former speakers have explained this, that this is becoming a very big issue everywhere in the world. Either you are living in an area where a conflict is ongoing, or areas where people are transiting, or where people are starting again to rebuilding their lives after an experience of torture. So this is quite complex, and I think it's the duty of all professionals. Either you are still studying today, or you want to work in the social sector, or you want to work in a medical sector, where you will know that at one time you will encounter these issues in your clinical practice, even if you think it is very far away from your reality. Rehabilitation, the functional rehabilitation aspect is very important in humanitarian settings, and especially when we talk about plain injuries. And we know that injuries in conflicts or occupational injuries in specific underdeveloped settings can lead to huge needs of functional rehabilitation. But then looking into the complex care that is needed for these for the victims and the survivors of torture, it is important then to look at how we can reach out to them in the best way possible to address their complex issues. one is, of course, teamwork. Now, I'm talking maybe of the perspective of a physiotherapist. Sue had been talking more about the medical and the nursing aspect. But of course, if we look at how a person can get surrounded by care that he needs, we talk also about social work. We talk about doctors, medical doctors, psychiatrists, sometimes psychologists, cultural mediators, the people that are going to help them to communicate with their environment. Because in humanitarian settings, as we know, when there is a concentration of displacement, you have a mix of their very different languages, cultures, and lived experiences, lived cultures that are very diverse. And when you need to set up care in these units, and then we talk mainly about refugee camps or displacement corridors, it is very challenging to organize that care so that people are able to communicate, feel safe in communicating, and even finding the right cultural mediators that are able to translate and to help them in getting around and expressing themselves with the therapist that will not be able to speak their language. So as a therapist, you need to be aware about this, about using your language, using the way you express yourself with your patients if you would be in a clinical setting. The other issue is, of course, as I said, the teamwork, that everybody needs to work for the patient. As a physiotherapist, of course, you will have your entry point on physical rehabilitation, that can go with all the different techniques that you have from your perspective. But you need to understand as well what a psychologist is doing, what is the workload of a social worker and the issues he needs to address. And of course, how the information, the key information on medical issues or psychosocial issues will come to you as well and need to be shared on a constant basis when you are in this clinical setting working with survivors of torture. As barriers and challenges that I see, and I will talk a bit later about it as well in the other points, we see that in general, that at least for functional rehabilitation, the exposure and the time that people have to have access to these services is sometimes very short in a lot of parts of the world because it's not available or the professionals are not available. And then, of course, the priority needs to see on how medical issues are addressed first. The basic issues, the basic needs are addressed first, and then people will only see if these basic needs are addressed or the medical and the urgent needs are addressed, how physical rehabilitation and functional rehabilitation can be addressed. So you will need to assess on how your list or your order of having access to a person with as a survivor of torture will be classified, meaning to know that there are priorities that you will have to consider first before that functional rehabilitation comes into the pipeline. And this is still a very strong desire and strong objective of working on advocacy in the future on this, ensuring that access is ensured. Another challenge is as well is on how we can show that functional rehabilitation is making a difference for the person, the survivor of torture, with specific outcome measures, knowing that, again, the exposure and the contact that we have with the survivors is very short. So measuring or observing progress or something that makes sense in a positive way to the survivor of torture to observe this is sometimes very challenging. And henceforth, it is also known that research and proving the approaches that you are going to choose with your patients sometimes are not always being proven. So you will have to work with a lot of perceptions, on seeing how your work has an effect and a change in the life of people with survivors of torture. As to the environment and care accessibility, the modalities and the impact on care and caretakers, of course, as I said, we need to see in what living conditions your patients are in the moment and how you are going to be paying attention to this. And again, looking at the priorities that person has for the moment and how you can address his priorities. The experiences I have been living mainly in the Middle East when confronted with survivors of torture had to do on one side where people would come to a specific structure, to a specific center, and going to seek for care there, where you have a team that can start the intake for the person, and then of course offer him all the different services available. On the other hand, we work also in the format of with community outreach programs, where you will go to seek the person in his living environment, and then from there starting a process of intake and a process of care that will offer him services as well. And both of them have their strengths and their weaknesses, of course, on which professionals need to be prepared as well. As we are looking at core techniques and competencies that you need to know to work with survivors of torture, well, the first one is, of course, I think I've seen a question about what techniques are available. Now, as physiotherapists, we know that our classical techniques have to approach, of course, the symptoms that you observe first with a survivor of torture. The first ones can be injuries, that need to be approached with musculoskeletal impact, and looking at how your classical training can address this in terms of managing the different MSK issues. The second issue is that knowing that that person has been living with pain, with sometimes loss of limbs, loss of functions, is to see how to restore that function, but then looking at how that function can be enhanced with a better awareness of his body, and working then with training awareness, sensory awareness issues, reconditioning, and very important then in case of flashbacks, the reactions that a person can have in terms of his breathing and control of body, and how you as a physiotherapist can propose him exercises and practices to better have a control over his body. And not only important to address this when you are in presence with him, but give him also the tools and a toolbox in terms of exercises, in terms of attitudes, in terms of know-how, that he can reproduce these skills once that he's going home. And if in the middle of the night he wakes up, he has a flashback, he can use these exercises again to take control over his body. And I think that is a very big essential point of the profession of physiotherapy, in not only being able to transfer these techniques to the person and the survivor of torture, but also to enable him to use it afterwards outside the clinical setting, outside the presence of a professional, so that he can reuse this again for his further life. Very special attention is put on pain management, of course, because we know that a lot of survivors have huge issues with pain. And here there are methodologies that exist, which is called the pain school management system, where you have in a set of sessions, people, the survivors of torture, and even their caretakers, they get educated on how they can learn to live with the pain, how to recognize it, how to select the pain in their daily living activities, and how, of course, then they can be able to have a different perception of that pain in their daily life, and how to look at how to better manage it and to better control it. And this is also a kind of new approach that we have been seeing, especially in the Middle East, with our partners from Dignity in Denmark, who have developed this methodology specifically for therapists, psychologists, and other professionals. The pain management school. More specific attention goes to outcome measures, and I said, how can we ensure that the impact of our actions are making a difference for the patients. We know that a pain scale, for instance, is a good tool on looking at before and after treatment. People have a different perception of pain. We look also on how the pain is influencing the daily life of a person, his daily activities, his daily living activities. So to see in how far that pain is playing a role in his functioning, and how then we can measure the preferred activities that the patient is expressing, and measure that with a pain scale to see, well, if I am doing my household chores, I feel more pain, or if I'm sleeping, I have pain as well. So we need to concentrate on which activity we can reduce his pain as much as possible in our general practice. Now, at the end, I would look also at the follow-up, the long-term follow-up. Now, I approach one point on, of course, giving the person the tools, the toolbox that he can reuse when he's back home, when he has flashbacks, when he has pain, and how our techniques that we have been transferring to him can be useful to improve his quality of life. On the other hand, there is also a big need of advocacy in the community to better understand the needs of survivors of torture, ones that have been identified. This is not easy in certain settings, but in other settings, I know where we work and where there is a better stability in society, we should, of course, also foster a better acceptance and a better understanding of what people have been going through, knowing that migrants, for instance, that are living in certain areas and that having been going to corridors of migration, they have all been experiencing a form of violence or an effects of this. And we know that there is also an advocacy and a better understanding that is needed for this. So this would also then enhance that the survivors of torture feel much at ease to seek care and to seek also and to expect also a better understanding of their situation in the community. So this is a bit in a nutshell, yeah, on these 8 points that I give a little bit my perspectives, and I look forward, of course, to your questions for the next part of the session here. And sorry for my voice because I got a bit of a cold in the last day, so I needed to be careful with my throat today. Thank you.
Thank you so much, Sue and Eric, for your very powerful presentations. I think they were very helpful and definitely provided some clinical guidance. So now it's time for the questions and answers. Before we get to that, here are the contact details for those who presented today. And again, you can find all of this information on the Physiopedia Plus platform. So I'm going to stop sharing my screen here. Panelists, please feel free to put your cameras back on. We do have a number of questions here in the chat box. So what I'm going to try and do is group them together because there were some common themes and we have about 15-20 minutes left for questions. So the first question that I'm going to ask is, how can we manage females suffering from any sort of trauma? Are there particular considerations for female patients?
I just wanted to say that I haven't really broken it down with regards to male and female, but I mean, of course, it's certainly a viable question. The thing is, I always go back to the principles, and I know it seems very, scholastic, but at the end of the day, if you're following along with the principles, if you make them feel safe, it's the number one thing to do for anybody, whether it's a child, male, female, LGBTQ, anyone who's just experienced trauma, first of all, needs to feel safe. And then they need to have somebody to trust because they've gone through a situation where trust has failed them. So you need to build trust. You can't do that immediately. All you can do is start the process to build on that. Using your peers and collaborating with your peers, you can all agree on how to go forward with a particular client in order to build the trust, so that if you're saying, I'm promising that I'm going to bring you in a meal at 5 o'clock and you have a whole half an hour to eat it. So make sure your peers are all in the same wavelength that, yeah, that's what's going to happen, just so that everybody's playing the same game. And then your client becomes more trustful and feels more safe in that environment. And I'd say it's the same for any client. And of course, if you're specifically asking because it's a female who may have gone through a rape situation, then what you may want to then really be cognizant of is who gender-wise is dealing with that particular client. And they may prefer having a female take care of them, and they may not want to have any males if it was a male that actually did the trauma. So that's the only things that I would take into consideration in that point.
Okay, thank you, Sue. So Eric, I'm going to direct the next question at you. how can we calm someone down in a clinical setting if they're reliving the traumatic situation? Do you have any coping mechanisms or anything that we can suggest for the clinician to help the situation?
Yes, of course, if you are in a situation where this can happen, and I know that from a practical point of view, when we were working in a clinical setting in the Middle East, there would always be people, cultural mediators and people facilitators, especially for the translators, who would play the first role in communicating the right language and the right dialect sometimes to make sure to ensure, because a lot of reactions can come from a misinterpretation of the language that is spoken. That is one issue, communication. The second one is that, of course, if physically that person gets quite agitated, we had a specific setting where there was a kind of where he would be brought into a room, that is being secured with soft walls and soft materials around him, and then to let him go to his crisis if he is not really responding to any of the propositions that we are proposing him. And I have been witnessing this in a specific clinical setting. Of course, if you are outside that setting, and I think that's probably what could happen most of the time in humanitarian settings, is to ensure that, as I said, go back to that communication, but preemptively, of course, if you are going to work with on a one-to-one situation as a physiotherapist with patients, you always you should not be alone all the time, of course, and of course that the caretaker is always around, or the person that is accompanying him should also play a role in that therapy to a certain extent, so that he can also be able to be better prepared and to be better resilient, because we assume that if this would happen in a therapeutic situation, this can happen at his home as well with his loved ones, where he would get violent, and then to make sure that that message or that possibility is explained as well to the members of his community around him. But frankly, if somebody really breaks down in front of me, in a flashback, and then that I did something, maybe did something wrong, of course, my presumption would be to try to calm down, to distance himself from me, and then finding people around me that probably have a better understanding of him, that are closer to him in terms of caretakers and in terms of cultural mediators that have more experience.
Thank you, Eric. A number of questions here asking about the pain scale that you mentioned and some of the outcomes that you mentioned. Could you repeat them, please? Just the name of them.
Yeah, there is the visual analogical pain scale. Yeah, it's a kind of ruler, where you have either figures from 1 to 10, saying 1 is less pain, 10 is a lot of pain, or with smileys, to saying with smileys, or people that have a sad face, by saying this is one way where we say, okay, you start the treatment and the patient says, okay, I feel pain. Where do you feel the pain? Of course, the location of the pain, and he will point them to that level of pain. That is one way to measure the pain before and after the intervention, or even before the sessions, the number of sessions, and after the sessions, so that you have at least something objective to exchange with the patient by saying, when you came in, you told me that this pain was at this level. Today, it's lower or higher, etc. That is one specific scale. Another one is, of course, to link that pain scale with a set of activities that the patient claims that he says, I would love to do. And most of the time it has to do with walking around, maybe playing sports for a certain time, carrying a child, for instance, for 10 minutes. And then he will select these activities, and you then have to work with him on how pain is going to play a role in these specific activities. And you're going to work with him on his preferred activities and measure the pain then to see what techniques, what approaches, what counsel, and what advice you can give him to better manage the pain during these 3 activities that he has chosen to be very essential for him and his quality of life.
Thank you, Eric. Sue, a question for you. And we'll try and keep it at about 2 minutes for an answer.
Okay.
How can you address someone who doesn't want to talk about it? Do you have any advice that you can give to a clinician to encourage someone to be a little bit more open with their experience?
I would say teaching. So, like I said in my presentation, you can assume that everybody sitting in front of you is got something in their past. There's much more to that person sitting in front of you than you're seeing. So instead of, if you've asked some pointed questions and they're not really forthcoming, then you can do a couple of things. You can say, some people think or say or have had an experience like this. I'm wondering, so you can set examples up for them so that they know that they're not afraid to say, oh, okay, other people have said that, then I can express that too. The other thing that you can do is teach them why it's important. Just let them know what we've already talked about with regard to adverse childhood experiences, that if you've had something happen, then there's a good chance that there's things that are happening inside your body, inside your brain, they're affecting each other, and that your health as you grow older is going to be adversely affected. So if you can just calmly talk to them about that, you may not get anything like a forthcoming response at that point in time, but it at least gives them something to work on. Let them know, hey, put a pin in that, think about it for a little while. We'll come back and talk about it again later. And you might get something then.
Just to add very briefly to that, in terms of to come back to the pain school sessions. And I think here we had also people that going into that program, and during the sessions, there are things that are explained to them, and it's up to them, let's say, to capture it or not. And then we believe that after a set of 10 sessions, people will not express, what's happening to them, but what they will be integrating, what they are hearing, they are going to integrate it and use it maybe as an example for their own resilience. Meaning that no, they're not going to explain about their flashbacks or their past on the pain issue, but on the other hand, the information that they received during the 10 sessions, they will integrate it and are going to try this for themselves for a better resilience and a better approach to their pain in the future. That is more a passive approach, where, of course, in humanitarian settings, we don't have much time for exposure on a long term to offer specific solutions to people and to be able to observe then an objective impact. Yeah. But more a passive information helps here also to help a better resilience for the person.
Great. Thank you for your answers, Sue and Eric. Just a reminder that there are more questions here than we can answer today, but I am taking note of all of them, and we will send them to Sue and Eric for their thoughts, and we will post the answers in the Physiopedia Plus forum. So if you're following the MOOC, you'll be able to see the answers there. Okay, so this next question I think is applicable to many different populations. At times, survivors of torture do not want to be touched. So how can you introduce that in a clinical setting for treatments and for evaluations? So Eric, do you have any recommendations to encourage that during treatment?
Yeah. That's a good question, because it's a reality. Yeah? I think that in the first intake process in any clinical setting, but probably at 80% of the time, you will not touch the patient. Yeah, because that's of course we will assume that as physiotherapists we need to touch, but of course, as I said, working on body awareness, working on explaining issues and talking with patients, and let's say that you are the one that is showing him a movement, he has to reproduce it. Well, of course, you can't avoid touch on this setting. The gender of the therapist is also important, and I know in certain settings, especially in the Middle East, we don't work with only one gender therapist. There always needs to be two different genders to work with. Otherwise, we feel that the care is not accessible. Yeah? But of course, that issue of touch is very important, but please, as a physiotherapist, you have a whole range of activities and a whole range of techniques that don't require touch. So you can then use the methodology of suggestion, relaxation techniques, sensory awareness that the patient will exercise on himself, by himself, with himself. That would be then the preferred techniques that you will apply if touch is not possible.
Okay. Did you have anything to add to that, Sue?
No, actually, I think that says it in a nutshell, because you can get away with doing a lot of things. I've also examined patients where I tell them to do the things that I would normally do to them. You know, can you put your knee like this and then move it like that? And how does that feel? It depends on the injury that's going on. But yeah, completely correct, Eric. That's wonderful.
Okay, great. So this is going to be the last question today for the live Q&A. Feel free to keep sending us your questions. We will address them, as I said, in the Physiopedia Plus forum. So this last question is talking about how to prioritize different types of rehabilitation. So oftentimes we will see individuals that have both physical and psychological issues that need to be addressed. How do you prioritize one over the other? So Sue, I think this is a good question for you.
That's a great question. I can see Eric smiling too. Honestly, as a psychiatric nurse, I'm right up there with you have to deal with the whole patient all together. And I guess that's where my trauma-informed care comes in, that you're going to be taking that client just from where Eric's got that person and he's trying to do an exam. I'm going to be making sure that the area around them is safe. I'm going to make sure that the client feels that he can trust both Eric and I, and that our team is there to help. So just from the get-go, all the little tiny things that you do with that client is helping with their psychological transition, if you will. And I would say concurrently is the best way to go, but I know you have to make choices sometimes. So flip of the coin, and whoever's ever strongest in the team wins.
All right, Eric.
Yeah. I'm quite familiar with what you were saying, Sue, as well, and and competing sometimes for attention towards the patients as such. I know that some intake processes that were done in a clinical setting were that the intake had to go first all the professionals available, and that they will do an interview, and then there would be a kind of interdisciplinary exchange meeting that would then set up the priorities and feed them back to the patient, and he would then step into first, of course, a medical examination, a psychological screening, or a talk, and from there they would see if people then are ready to go for the other activities. That is quite one model. Another model is more like the community outreach, where you look at priorities, and then probably you are confronted with people where the issue of torture has not been detected. And then you take, of course, more time to look at a specific injury, a specific pain complaint, on which you are going to work and build with your therapeutical arsenal on either a pain school approach, by not identifying that person as a survivor of torture, but just answering to his request on the pain that he feels, the injury that he has, and of course the suspicion of specific behavioral issues, with our psychosocial colleagues, that they will discuss this as well. So you have different intake pathways according to the setting where you are work and the level of specialties that you have available.
So this brings us to the end. This is all the time we have for questions. I did take note of the ones that we didn't get a chance to answer today, but I wanted to say a heartfelt thank you to both Sue and Eric for your time today. Naomi as well, obviously, for all your work on the MOOC. So thank you everyone who participated today for your kind attention and consideration. We truly hope that you found the information helpful and particularly helpful for your clinical practice. So please be in touch if you have any questions, and we're definitely looking forward to your feedback. So I hope you found it helpful, and everyone have a wonderful day and a wonderful evening, depending on what time it is where you are. So thank you and have a wonderful day. Take care, everybody.